You're welcome.
So welcome everyone to the Innovative Discoveries Series. Before I introduce today's speaker, I wanted to go through some of our standard housekeeping items. We continue to extend CME credits for these Innovative Discovery Series sessions and our Tech Talk presentations. We'll distribute the CME information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain the CME code information from Lisa Maturo at Christiana Care. And Lisa kindly provided her email address in the chat for those who'd like to reach out to her directly. It's lisa.m.maturo@christianacare.org. You can just see it in the chat. Upcoming in our Innovative Discovery Series, we next have on June 18th, Dr. Christina Bethel from Johns Hopkins University. Dr. Bethel will be talking about translating the science of child development into policy and practice using family-centered data and tools. Following that, on July 8th, we will have our next Tech Talk with Dr. Bethany Wolf from Medical University of South Carolina. And stay tuned for more information about the title and subject of her talk. So with that, it is now my great honor to introduce today's speaker. Dr. Ted Corbin is Professor and Vice Chair for Research in the Department of Emergency Medicine at the Drexel University College of Medicine. He also serves as the co-founder and medical director of Healing Hurt People, an emergency department-based trauma-informed intervention for victims of intentional injury. Dr. Corbin also co-directs the Center for Nonviolence and Social Justice at the Drexel University Dornsife School of Public Health, where he holds a joint appointment in the Department of Health Management Policy. More recently, he has been appointed as the Associate Dean for Community and External Affairs for the College of Medicine. Dr. Corbin's research focuses broadly on addressing the trauma in the lives of victims of violence, especially boys and men of color, for whom violence is the leading cause of disability and death. He has received funding from the Philadelphia Department of Behavioral Health and the Annie E. Casey Foundation to explore the impact of PTSD on violently injured youth and young adults, and to evaluate the effectiveness of the intervention that he developed through the Healing Hurt People program. He is also the principal investigator on the Department of Justice and Office for Victims of Crime grant to develop and test a community health worker peer training institute, which is designed to enhance and diversify the healthcare workforce. Over the past 10 years, Dr. Corbin has received in excess of $9 million in funding for his translational work as a principal investigator. Dr. Corbin received his Bachelor's of Science in Biology from Lincoln University and his MD from the Drexel University College of Medicine. He also earned his Master of Public Policy from the Princeton University School of Public and International Affairs, and he completed his residency in emergency medicine at Howard University Hospital. He is board certified in emergency medicine. Dr. Corbin has received a number of honors, including a Soros Physician Advocacy Fellowship from the Open Society Foundation and a Stoneleigh Foundation Fellowship to support his career and development in serving the needs of vulnerable children and youth. He was selected as one of Philadelphia's 40 under 40 leaders in 2006. And Dr. Corbin has provided expert testimony to the Defending Childhood Task Force, which was charged by Attorney General Eric Holder to speak on his work in addressing adversity and violence in urban youth. Dr. Corbin has also provided practice-based evidence to the National Academy of Medicine on public health approaches to violence intervention. All that being said, it is a great honor to have Dr. Corbin here with us today, so please join me in giving him a warm welcome. Dr. Corbin, I see you have your screen up. I see your video. Are we good to go?
Can you hear me okay?
Yes, we can.
Oh, awesome. Thank you.
It's the fun of virtual meetings.
Right? I was panicking there for a second. I'm a little new to Bluetooth.
We would have figured it out.
Kimberly, you're all too kind, and thank you so much. And thank all of you for inviting me to participate today. I just want to let you know I have no disclosures. And what I hope to do during the time that I'm with you is really to have a conversation about exploring opportunities to address some of the social determinants of health adjunctive to medical providers, to describe a hospital-based and community-linked violence intervention, and also to study programs using mixed methods, which is something that I've come to really appreciate and have learned and continue to learn more about, and also to introduce that novel approach of qualitative study to a necessary program, our hospital-based violence intervention program for survivors of violence. I want to first start with a video, very brief, it's probably 2 minutes long, of one of the participants in our program. His name is David Green. He's given us permission to share this for educational purposes. But I just want you to take a moment and just listen to pieces of his video. He participated in the program as I mentioned, and he really does. This is part of a healing circle that takes place to really get our young people to recognize, identify, and understand some of the symptoms that they're experiencing. Take a listen.
None of the people I knew in the sandbox is alive today. I was shooting basketball with friends at the playground the first time I saw someone get shot. It was random. I didn't think something like that would happen to me or my family. I have seen a lot. Now I don't sleep at nights. Last year my cousin was killed at home in his bed. While everyone is sleeping, I stay awake. I go to sleep in the morning when people are up and moving around. When I do sleep, I have nightmares. Sometimes I wake up crying, feeling lonely, wanting revenge. I wake up paranoid. But there was something that really hurt me, even more than when I got shot 3 times. I was sitting in the street with my brother's head in my lap. Dude stood over him holding a gun before running away. Dude just left. There was nothing I could do. My brother wanted me to hold him. I was crying, panicking. He said, "I'm going to be all right." Little did he know, he wasn't. After that, I knew I would get shot. I started imagining how it would be and how I would hold my body so that they wouldn't shoot me in my heart or my head. When walking in the streets, I would think about how to turn my body so that the bullet would hit my shoulders and not my heart, or how I would use my hands and arms to shield my head. I'm always looking back over my shoulder at my own shadow, hoping that one day I would stop focusing on my past, but looking ahead to my future.
So thank you for that. And I just wanted to bring your attention to some of the things that often go unaddressed in when caring for patients that have been impacted by violence. And across the country, this is something that we've all been contending with, and realizing that in many instances, trauma really is at the core of many of the issues that don't necessarily go unaddressed. And when you think about post-traumatic stress disorder, we want to think about those different components of hyperarousal and hyperactivity, re-experiencing intrusive symptoms, emotional numbing and avoidance, and negative alteration in cognition and mood. Now, I want to draw your attention to the emotional numbing in some instances, because this, in some ways, is really pervasive and somewhat misconstrued when delivering care, because when taking care of some of the young people that have experienced a lot of trauma, this comes across in some ways of folks lacking remorse because they're quiet and not really answering questions that might be directed at them. And so just something to pay attention to when we're caring for our individuals. I shared that about post-traumatic stress because it relates to the story that David told us. You heard him say that none of the people I knew in the sandbox is alive today. You heard him say, my cousin was shot in his bed. I don't sleep at night. I have nightmares, wake up crying, feeling lonely, wanting revenge. My brother wanted me to hold him. I was crying, panicking. After that, I knew I would get shot. And so you hear trauma, more hyperarousal, sadness, depression, re-experiencing more trauma, and then hyperarousal, feeling like he knew or thought he would get shot. And so this is something that many of our young people are experiencing, and we are really working to combat that and also destigmatize it, because as we know, there's lots of stigma that's associated with any type of behavioral health or mental health, sadly. This is a statistic in Philadelphia that I'm sure many of you are familiar with. I'm sure there's similar activities or actions happening in Wilmington or the thereabouts in Christiana, realizing that you're a level 1 trauma center. In 2020, we saw that there were 499 homicides, but that is just the tip of the iceberg. Though devastating as it is, there have been 1,849 non-fatal shootings. There have been a total of over 2,000 shootings, and then we see that there are over 5,300 aggravated assaults. And nationally, these numbers are consistent that the number one cause of death among African Americans between 15 and 34 is homicide, and it's the second leading cause of death among Hispanics between that same age range. And so, and there's evidence that we know that shows that if someone is shot, based on a study, if someone is shot or experiences a penetrating injury, in 5 years, the likelihood of that happening again is up to 44%. Some studies have shown it as high as 47, 48%. Of that same population at 5 years, 20% are dead, sadly. And so we think about this vicious cycle in that someone comes in who's shot, stabbed, or assaulted. These symptoms of PTSD that some of our patients are not familiar with start to develop some of those symptoms. And not having access to care and not being familiar with those symptoms, they sometimes revert to using marijuana or some other substances that would help them quell some of those symptoms. And then when they do attempt to get a job or some type of employment, if there could be drug testing that happens, and so this removes them from the workforce because they will test positive. And we know historically that the police have been not trustworthy to many of our communities, particularly our communities of color. And so when we see that the police are not there to protect us, they revert to getting a gun to protect themselves and or their loved ones. And that sadly lands them in jail or dead. And so again, this is not new, even though it's more recently it's been brought to our attention. But we know of Rodney King in 1991, Abner Louima in 1997, Amadou Diallo 1999, Sean Bell in 2006, and Trayvon Martin as well. And then we've also heard of our more recent killings with last year here in Philadelphia and also in Minneapolis. And we, as I mentioned, we've seen many of these high-profile police killings, but it's not until, I mean, there have been narratives about this, but it hasn't been until it's been put on video that things are actually moving, unfortunately. And so I'd be remiss to talk about this work without talking about racism in amidst all of this. And the best definition that I've come across is that of Kamar Jones, where she says a system of structuring opportunity and assigning value based on phenotype, which is race, that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities, and it saps the strength of the whole society through the waste of human resources. And I feel that this is applied in so many settings. It's applied to police and it's applied to healthcare as well. We also know that there are different levels of racism that Dr. Jones has talked about, that of institutional, personally mediated, and internalized. I don't want to get into details about that right now, but just realizing that there are different levels of racism that are working in many of the places. Also, thinking about the social determinants of health, we know what they are, but also playing in all of these social determinants is that of racism. And it does have huge implications and impact on health outcomes. And then we move to racial trauma, which is, it can result from major experiences of racism, such as workplace discrimination or hate crimes, or it can be the result of an accumulation of many small occurrences, such as everyday discrimination and microaggressions. And a perspective that we've taken in realizing is, how do we heal from racial trauma, recognizing that many of our patients that we see through our violence intervention program are people of color. And there's a process that has to happen. And first is recognizing those wounds of racial trauma. And those have been identified as devaluation, assaulted sense of self, internalized voicelessness, and rage. And what we've applied in terms of our practices are those of healing. And it's affirmation and acknowledgement, creating a space to have a conversation about race, racial storytelling, and rechanneling the rage that many of our patients experience. And it's just one thing on top of the other, because, even in a time where, where we're confined to our homes during the pandemic, and, there's still ongoing trauma where we thought there might be a decrease, there was actually an increase in violence in many of our cities. And then we saw that with the police and police racism and uprisings, all of that just really piled on to one another. And so I moved to what we can do and what we're doing. And so I'm going to briefly talk to you about Healing Hurt People, which is a hospital-based violence intervention program that was conceived listening to the voices of young people that have been victims of interpersonal injury, and also having a conversation with care providers in terms of what they think could be done, but also listening to the young people to hear what they feel should be done as well. And after exploration and getting to understand all of that, and through a series of focus groups, we recognized how trauma-informed care and trauma-informed practice was essential to have a part, to be the undergirding theory of practice for how we address our patients. And that does, in fact, take into consideration psychological and spiritual, not just the physical wounds of violent injury, that they do, in fact, need to be addressed. It acknowledges the pain that patients have experienced over the course of their lives, both personal and structural. And so when we think about racism in there as well, and then it understands that trauma feeds the cycle of violence. And we're looking at ways that we could intercept that. This is a very simplistic, non-exhaustive way that we think about the cycle of violence. And so, if you start at 6 o'clock on your screen, you see a young person or a person shot, stabbed, or assaulted is brought to the emergency department. Medicine is such that we are sophisticated and skilled, where we're really good at taking care of violent injuries. And interestingly, for every one person that's admitted to the hospital, 9 people are treated and discharged from the emergency department. So that one person that's admitted potentially may be introduced to other resources. But then there's the other 9 people that are usually discharged, that are often discharged for the for their injury. And so we see where we have an impact or a role and a responsibility is the hospital-based violence intervention program. That's what HVIP stands for, is to really have an intervening aspect where we can address those issues of trauma and pay attention to it. And what we often see and recognize is that trauma is at the core of many of the young people that we're taking care of. The process by which we work is anyone who comes into the hospital, we see that as a window of opportunity, and we recognize, understand the consequences of trauma, not just the physical wounds that require follow-up care, but those emotional wounds, understanding that people might want to self-medicate and realizing that there are a myriad of other things that they potentially have going on with regard to joblessness as well as court involvement. And we work to do an assessment, to provide some psychoeducation, to do some case management, counseling, and we also have groups that are culturally responsive, healing groups. And our goals in the end are to ensure that the person and their families are safe, that they're able to manage their emotions, that they are able to heal from some of the racial trauma that they've experienced, envision a future, get them connected with care and appropriate follow-up care, and then really connect them to the grid of opportunity, because many of them are not connected to some of the opportunities that are available to them or even knowledgeable about what they might be. And so we see, though we do have a presence in hospitals right now, we have a presence at St. Christopher's Hospital for Children. We have affiliation agreements with Jefferson, Penn Presby, as well as Albert Einstein. And so that identification is made in the hospital or in the emergency department, and our team will connect with them, be it at the bedside, or it might be at home or in a community if the person feels safer meeting in a common space. Just to let you know that hospital-based violence intervention programs have been around for some time. There's probably about 49. We were fortunate to be part of the founding organization, the Health Alliance for Violence Intervention, which disseminates best practices and advocates for policies so that programs such as these are in place to help decrease re-injury, decrease violence in certain areas as well. And there have been studies that have been done at these various intervention programs. Baltimore showed that there was decreased involvement with the criminal justice system. Richmond, Virginia showed increases in the use of social services and decreased substance use. Also in Oakland, California, decreased involvement with the criminal justice system. And San Francisco showed a decrease in re-injury. And you see it extends. We realize that violence isn't just a national problem, it's an international problem. So there are programs across the lake in London, as well as El Salvador, and Winnipeg, Canada. Also, Indianapolis showed that there was a decrease in re-injury as well in Chicago. We have a team of individuals that make up our team, which is a team of counselors, which are social workers, as well as community health worker peers. And we work to, as I mentioned, really address those psychological wounds, also get them connected beyond the services that we provide to them, be it primary care or follow-up trauma care. And also our efforts are around meeting them where they are. We've superimposed a study to the program to, of course, look at the outcomes, but it's also really to ensure that we are doing what we should be doing in terms of improving the outcomes. Now, many of the studies that that are funded nationally are interested in looking at this: violent re-injury, arrest for violent crimes, and also in the big picture, have you decreased violence in the city? And we know that it takes more than just addressing just addressing violent re-injury. And we would also say that we see our space in the healthcare space, but there are so many other spaces that are in need of violence prevention and intervention programs. We see our slice of the pie here, but we also see the need to partner with other programs and organizations that are in the community, or in some instances that are in different spaces such as schools. So we do in fact partner with them. But even though we are interested in those long-term outcomes, we are really interested in how we're making sure that our patients do better and feel better. And so we're looking more proximally at things like depression, post-traumatic stress, drug and alcohol use, sleep quality, personal mastery, social support, and self-rated health status. And so we were fortunate to have we have our program originally it was at Hahnemann and St. Chris, but as we were replicating at the other institutions, we had the opportunity to embark on a natural experiment. And so folks that came in through the doors of, say, Einstein, and Temple was involved at the time as well, but the program was not, we didn't have the capacity at that point to implement the program there. And so we consented folks that were violently injured to see if they would be interested in the violence intervention program. And if they were, would they be interested in participating in some research? And so from there, we got consent and we asked them the same questions that we were asking those that were involved in the violence intervention program. So it was a type of step wedge model. And as we ramped up in those various hospitals, we collected our controls. Now we did offer, once we ramped up at that particular facility, we invited the control group members to, we invited them to be part of the program, Healing Hurt People. And so we did collect information at baseline 6 weeks, 6 months, and we also did qualitative interviews at that 6 months as well. And we did use an audio computer assisted interviewing process just to eliminate any interviewer bias, as well as recognizing that so they could listen to it, but then it was also read. They could read it and they could listen to it, accounting for any literacy challenges. And so preliminarily, we looked at some of the data in terms of PTSD, depression, sleep disturbance, and perceived stress. And what we did see, you'll see in blue are the control, in orange are the intervention group, those that receive services from our HHP team, and recognizing that it was the services that were not necessarily uniform, but they did receive counseling, evidence-based counseling, and they also received case management and health navigation. And so, surveys were administered to them at different times. And what we saw was that there was definitely an improvement in depression scores, sleep disturbance scores, and perceived stress. Now, there was a slight improvement in the intervention group with regard to PTSD, but there was also a slight improvement in the control group. And so we wanted to recognize or reconcile what it was that we needed to do to improve whatever modalities we were doing to address those symptoms of trauma. And so we did adopt a new modality, cognitive processing therapy for the adults, to see if in fact that would make a difference. And so we're in the process of analyzing that data now. And so I want to I mentioned that we're interested in mixed methods, and we did survey results, and we do have a robust and rich number of interviews from the participants, both control as well as as well as the intervention group. And so we wanted to realize that we wanted some research. There was research that we needed to address racial trauma that was narrative, multi-methods, and recognizing that it's intersectional. And that's where I became familiar or started to familiarize myself with configurational comparative methods. And I'm not going to get into detail about it, but just something I'm pretty excited about is in that there are different types of configurational comparative analysis. It's based on set theory and Boolean algebra, and also aim to understand complex causation. And there are different types. There's qualitative comparative analysis as well as coincidence analysis. And just to give you some characteristics, we think about conjunctural causation, which is a single where single conditions display their effect on an outcome only in combination with, that means the presence or the absence of the other condition. There's equifinality, which is the ability to identify more than one causal pathway to an outcome. And then causal asymmetry, which is causal pathways for achieving the outcome differ from the pathways for failing to achieve the outcome. And just to what I have come to understand this to be is that we realize that we're looking for a particular outcome. And I'll give you a specific example in a second. We're looking for a particular outcome. But there are different ways to get to that outcome. And realizing that it could be the presence of something or the absence of something or the presence of a few things that could get to that same outcome. And that's what's pretty intriguing to me, because it also recognizes that our patients are not monolithic and that there are complexities that go along with them. And so recognizing and understanding that there are different pathways to get to an outcome is really what this methodology embraces. And so one study that my partner, my colleague, and I and some other colleagues took part in is really is to use qualitative comparative analysis and looking at help seeking, psychological help seeking as the outcome. And the aim, really was to use qualitative and quantitative data from young Black men who were survivors of trauma and try to understand how symptoms of PTSD and depression may act together with discrimination, stigma, and financial stressors to either hinder or facilitate their help-seeking behavior. And so this is something that I'm really excited about. We've collected a large amount of data, a large number of stories, interviews with some of the patients that have participated in Healing Hurt People, as well as the control who initially did not have access to a program. And we're in the process of culling that data as well and applying this method to see what the outcomes are. But we're also looking at these outcomes to ensure that we're providing the best deliverable services to the patients. And so more to come, and I'm looking forward to sharing that with you and with others. I'd like to end with a quote from someone that I admire in many ways, and it really does apply to the work that I've been doing and that some of my colleagues do, is that there are three ways in which we can deal with injustice. And I would also add health inequity. And one can accept it without protest. One can seek to avoid it. One can resist the injustice nonviolently, but to accept it is to perpetuate it. And so our efforts here are really not to accept it and to go against the grain and to do something different. So with that, I thank you and I welcome any questions.
Thank you so much, Dr. Corbin. That was very powerful. I have a couple questions, but first I want to open it up to the group to see if anyone else has any feedback, thoughts, questions, insights.
Hi, this is Dave Chen. So thank you so much. I've been following and admiring your work from a distance for years and deeply appreciate the model and the precedent that you've set in really trailblazing this, as well as with Dr. Rich. We are very happy to say that we've been launching our own HVIP. We're 4 months now into launch. We've begun essentially having our initial cohort and everything for it as well, and have followed, I think, literally trying to collect a lot of these measures. One thing that I've noted in combing through the literature as best I can is that it's very difficult to form these comparator groups for any sort of evaluation, in part because of, I think, a lot of the drop off the follow-up, and kind of ironically, or not ironically, those that we intervene with were more likely to have that longitudinal data to be able to then reassess, whereas those that are not being engaged, almost by definition, tend to not then have that follow-up. How do you work with that? And especially for a group such as ours, where our numbers are on a much smaller scale, especially in starting up, than in larger cities or larger programs, to be able to do any kind of reasonable analysis for that. And so, yeah, I have so many questions, but that's kind of one big one.
Thanks, Dr. Chen. We've exchanged emails several times, so I am glad to know that your program is up and running. Yeah, I think follow-up is always a challenge, even with some of the clients that are actively participants in our program. What we were fortunate to do, because of the process by which we were ramping up at the other institutions, and we were fortunate to have some incentive to go along with that. We were actually able to follow those that were in the control group, and I would, and part of the reason that we were inclined to go that route is there was a little bit of an ethical dilemma that we had, that because we knew that the services that were being provided were in fact connecting folks to the resources that they needed, and also they were doing better just based on the scales that we were administering. And so the idea of having a control group where you're not giving them services was really challenging. But you're absolutely right that follow-up for those that are non-participants is challenging, because follow-up for those that are participants is challenging. And so this is why we felt that I've more recently been exposed to this notion of data justice, where we don't necessarily look at the bad aspects or the negative aspects of what could happen when you don't get the services or aren't exposed to those services, but rather paint a narrative and tell the story of what and how folks are benefiting from the different services that are being delivered. And so that's why I'm pretty excited about applying, this different methodology to look at, because there are so many different pathways to get to a successful outcome. But we also can look at what is not so successful, because we want to listen to our patients to hear what are their goals, and we try to let them name, or we do let them name 3 to 5 goals. And ideally, we want to at least achieve 3 of them for us to be successful. But then we also have a battery of scales that we're administering as well. And so what if we don't achieve any of those goals, and what if they don't show any improvement? We want to look at what those different pathways, or what was missing, or what was present, to see what got us to that unsuccessful pathway. And so that's why I feel like this methodology speaks volumes to me in applying it to a population that's challenging to follow up. And I'm happy to talk more to you about that offline and share some of the instruments and also this study methodology that I'm looking forward to applying to the study.
Any other questions? Well, David, you're welcome to ask more questions if you have another question. Please, we would welcome it.
So one thing that we are kind of coincidentally involved with now is when violence surges, clearly a lot of different partners and groups are interested in also doing interventions and programs and things like that simultaneously. And so in our fairly small city, there are both community groups as well as the justice system and the policing system specifically that have launched their own initiatives concurrently. And so it's been challenging for us to figure out how to account, if possible, for those kind of confounding interfering, I shouldn't say interfering, sometimes synergistic factors for that. But given how complex a lot of these factors are to begin with, it's already challenging doing it within a single program in terms of trying to account for those different factors and interventions and strategies and methods. How do you, and is it possible to build a common language across different institutions, different programs to set comparable metrics, or is that sort of perhaps too ambitious or too much of a goal? To be specific and to put a point to it, one very sort of popular, prolific program is the group violence intervention, associated as a kind of in parallel with a lot of policing strategies, arguably in conjunction with policing strategies. And I know there are a number of cities where this has been starting up, and I know from what I've heard that Philadelphia is also beginning to develop and has been launching its own GVI program as well. How have you been thinking through how to account for those?
Yeah, that's a great question, and it is absolutely challenging. We do have we're partnering with the public health department, for which one of the program director, the injury program director at the public health department is in fact trying to figure out what some of those common data elements might be across the various intervention programs, because and again, I feel that we need all of them because this issue is so big and so great. And so she is working on, along with us and some of the other partners, at some of these data elements and where any of our clients or patients might intersect, because some may not. But I hear what you're saying in terms of how one might influence the other in some instances. But the idea is at the city level, we are working with someone to develop some common data elements to see if, in fact, again, looking at what that outcome might be. But again, I would stress that again, I'm biased here in part because I see the value in configurational comparative methods, that again, there could be someone who's involved in your program and someone involved in group. That same person could be involved in the group intervention. But again, just what is it that you're providing? What is it that they're providing? But then also looking at someone who might not be involved in any of those services and seeing what the difference is, and seeing it, but looking at the same outcome. So again, I think it is definitely a challenge, but it is somehow, and I know that you've been collaborating with some of the other organizations, but it is somehow setting up some panel of common data elements that each program can collect.
David, that's fascinating, Dr. Corbin, to to think that there could be some way to capitalize on this, the mass expansion and replication of this program to, have some sort of some of the elements standardized to be able to kind of look across programs. That would be incredible.
Yeah, and I think folks are really, I think healthcare has really figured out that it is a quality issue. I mean, providing these services, our program, though it does focus on violently injured people, in some ways it's a proof of concept to see that, services need to go beyond the walls of the hospital. And so the community health worker peer model in chronic disease, diabetes management, as well as heart disease, heart failure. There's ways in which we can, again, involve folks from the community to be partners in healthcare delivery in that regard.
I know you addressed this a bit, but I wanted to ask more about the barriers you experienced to, retention in the program. Did you also experience barriers in engaging people in participating, or, and if so, for either, what are some of the strategies you use to address that for engaging people in the program and retaining them in the program?
Right. Yeah. Thanks for that question, Kim. So yes, there have been challenges engaging and retaining. In large part because there's historically been a mistrust with healthcare, and again, looking back at the statistics, the large majority of people being impacted by violence are Black and brown people, and then the history of mistrust, not just with the police but also with the healthcare system, and so just a quick story is that when our team, and we have a really diverse team of people that are community health workers and social workers that approach people in the hospital, they thought they were the police. And so automatically they're going to shut down and not want to participate in any way. But it does in fact take some common experience, understanding. What we've found is that our community health workers are able to connect better with our patients than sometimes the physicians, the nurses, and others in different instances. And so that has been our way to engage. And really, we have probably about an 80% engagement rate with the folks that we approach, and it's not necessarily on the first try. So it does take a few times before we're able to engage them. With regard to retention, because now COVID notwithstanding, because we're in some ways we're out in the community, so we're not relegated only to the hospital. We do go out to the community. So there have been instances when there's a meeting or a scheduled follow-up with either our social worker or our community health worker peer, and the person doesn't show, we might call them. In some instances, we may even go to their home because we just want to ensure that, ensure their safety. And so we have a pretty astute and aggressive group of folks that really want to ensure that our patients are doing well and are in receipt of services. So, but it's not easy by any means.
I'm sure. I mean, it does sound like that's very resource intensive too. On average, how many people do you have in the program at a given time? So like in terms of like that follow-up, does that require large number of staffing resources?
Yeah. So we have on our team currently, we have 3 social workers and we have 3 community health worker peers. 4 social workers and 3 community health worker peers. And at any given time across our entire team, monthly we probably have about, I should say, each person carries about 15 people in terms of caseload. So anywhere from 12 to 15 per month each person carries in terms of the caseload.
That's really helpful to know. I feel like sometimes those logistics are just as important.
Yeah, for sure.
But yeah, and try to give people the appropriate, the patients, the participants, the appropriate contact and attention they need. Yeah.
Yeah, and the pandemic has really we see it in a different way here because our team had to pivot to telehealth, and so that was in some instances easier because for whatever reason folks were a little bit more inclined to engage this way or through FaceTime. Of course, we had to ensure everything was HIPAA compliant, but that was the modality that we were using. And again, just as challenging in some instances was the calling and the calling and the calling to ensure that we could make the appropriate follow-up in some instances. Sometimes we did, sometimes we didn't.
That's fascinating. I'm sorry, I keep asking questions. So if anyone has any other questions, please feel free to jump in. Did want to ask, do you intend to continue the telehealth component?
Oh, for sure. Yeah, we're going to use it as an option. We do plan to return to the office and return to some activities of home visits. That was really one of the most appealing pieces of the program to the clients is the home visits. And so home visits or meeting in a common place, a mutual space was one of the big things. But there have been advantages to connecting via telehealth. I mean, connecting on this virtual platform, transportation costs and things, or just transportation in of itself have been challenges, just in the usual day-to-day.
I have another question, but I don't want to monopolize the conversation. So does anyone else have any other thoughts or questions?
I also have more questions, but don't want to monopolize the space either. One question that I think does have broader application too is the community health worker component. And so we do have a community health worker and social work as well. And the quality and I think the trust in that conversation, that contact just is very difficult to put a price value to, just because of how great that engagement is, but also how difficult it is to capture the quality of that and to really explain / justify all those things. I know Connecticut recently, I think, passed legislation to embed reimbursement for CHWs into Medicaid. And I think Pennsylvania has been trying to do that for quite some time. And I believe your group was pioneering a lot of that. Can you speak to what the significance is of that in terms of having Medicaid being able to reimburse for services, as well as what the barriers are to that? Because I think it is very reasonable for us to push for that here in Delaware, but trying to negotiate or navigate those problems.
Yeah, I think it is. I think it's just, again, it's imperative that there be reimbursement for these services. And like you said, it's hard to capture the quality of that, but as healthcare providers, we all are also committed to documenting. And so that has been the piece that is both challenging but then also necessary. But we do see the value of Medicaid reimbursement, at least being, it's not going to pay for all of the services, but we realize that it does provide some level of backbone support for the work that's being done. And then, we feel, committed to looking for other resources that would support the work But I feel like this legislation is really important. There is potential for it. We do have it through behavioral health Medicaid, because we're delivering some therapeutic services or evidence-based practices around, as I mentioned, cognitive behavioral therapy, cognitive processing therapy, and also including some of the motivational interviewing as well as peer support and health navigation as reimbursed by the work of the community health worker peers. So it's all in the documentation, it really is, and it's always challenging to encourage folks to document everything that's been done, but it does really make a difference in reimbursement especially.
From a research perspective, have you done any sort of qualitative like interviewing of the providers, of your staff or your team in terms of their experience?
A great question. We have, and again, that's something that we're in the process of analyzing, but absolutely. There's a program in Boston, it's called Boston Violence Intervention Advocacy Program. They actually did publish a paper on the experiences of the providers in their program, really profound. And it does speak to the shelf life of that particular role, that position in these types of programs.
Well, we have 1 minute left, and I want to be respectful of your time, Dr. Corbin, and our audience's time. But I want to just one last round of any questions or thoughts from anyone? All right. Well, thank you, Dr. Corbin. This has been such a pleasure. We greatly appreciate you sharing this really important work with us. It's been very insightful and, as I said, powerful. So thank you. We really appreciate it.
Thank you. Thank you so much for the invitation, Kimberly. And thank you, everyone.
Thanks all. Have a good weekend.